Okay, Megan. Okay, welcome everybody. Uh, we welcome you all to this LA CATS retreat plenary talk, which is also serving as institutional grand rounds for our institutions, Tulane, LSU, a very special lecture with a very special guest. Uh, as you know, I probably know most of you, I'm Vivian Fonseca, and this program is organized by the Professional Development Corps of LA CATS. And we're also pleased to have our current LA CATS Director, John Coburn, on the line, as well as our former LA CATS Director, Will Cefalu. And it's a great pleasure for me to welcome our special guest, Griffin Rodgers, who is the Director of the National Institute of Diabetes, Digestive and Kidney Diseases, or NIDDK at NIH. He's been in that position since 2007, having previously been interim and was the Deputy Director before that. He received his undergraduate, graduate, and medical degrees from Brown University, then did residency at Barnes in WashU. He has subsequently worked at NIH in hematology, also did an MBA with a focus on the business of medicine and science at Hopkins, and a master's in legal studies in 2017. He's a very notable research investigator, and his contributions led to the development of the first effective and FDA-approved therapy for sickle cell anemia, which we use a lot here in New Orleans. In addition, his collaborators have reported a stem cell transplant regimen that is highly effective in reversing sickle cell disease. He's been honored for his research with numerous awards from several foundations, including the Rosenthal Foundation, the Fleming Award, the American College of Physicians, and a fellowship of the Royal College of Physicians in London. He's a member of the American Society of Hematology, American Society of Clinical Investigation, Association of American Physicians, and several others, and the National Academy of Medicine. So Dr. Rodgers has been very gracious in agreeing to come and talk to us today on the future of research at NIDDK, which in a way will reflect where we go with research in general and with a focus on clinical and translational research. Thank you for coming, Griffin, and it's a great pleasure to have you in virtually today, but hopefully soon you'll be able to visit us in person.
Absolutely. Well, thank you for the very kind introduction, Dr. Fonseca, and thank you for the invitation to speak here today. You know, it's been said that you can live in any city, but New Orleans is the only city that lives in you. And so it's always good to return home, even if it's virtual, as in this particular circumstance. And it's just a pleasure to be here today to give you a NIDDK perspective on the future of clinical research. If I can have the next slide, please. In my talk today, I will provide a brief overview of NIDDK and its mission. Then I'll focus primarily on diabetes and with some discussion of obesity and COVID-19 as well. And then I'll close with a few words on our training opportunities at the NIDDK. Next slide, please. You know, as our name suggests, NIDDK's research mission is broad. We support and conduct research to combat diabetes and other endocrine and metabolic diseases, liver and other digestive diseases, nutritional disorders, obesity, kidney, urologic, and hematologic diseases. If you can click. All of these diseases are common, they're chronic, they're consequential, and they're very costly, and they're affecting people in this country. Now, click, please. Now, this slide depicts just 3 of our most burdensome chronic conditions affecting Americans today: obesity, type 2 diabetes, and chronic kidney disease. And at NIDDK, we integrate our support of research of these conditions because they're connected, and people are not likely to develop just one of these health problems. And as you can see in the gray boxes, A staggering number of people are affected by these diseases, and complications from these health conditions can lead to a lifetime of pain and suffering. And all of these conditions are associated with the US health disparities. For example, as you can see in the light blue boxes, obesity disproportionately affects non-Hispanic Blacks, Hispanics. Type 2 diabetes rates are higher in American Indians and Alaska Natives, non-Hispanic Blacks, Hispanics compared to whites. And also compared to whites, rates of end-stage kidney disease are 3 times higher in non-Hispanic Blacks and 1.3 times higher in Hispanics. So these disparities are further exacerbated by the ongoing novel coronavirus pandemic, and with increased rates of infections and disproportionately poor outcomes from COVID-19 seen in individuals with these same conditions. Next slide, please. Briefly, here's a closer look at the staggering cost of diabetes, for example. Now, the NIDDK supports and conduct research on all types of diabetes mellitus, but I'm going to focus primarily on type 1 and type 2 diabetes. Next slide, please. First, type 1 diabetes, as this slide shows, we seek to conduct groundbreaking research covering the spectrum from the initial risk for type 1 diabetes through advanced stages of the disease. And since 1998, this work has been made possible in part by the Special Statutory Funding Program for type 1 diabetes, also known as SDP, created by the US Congress. Next slide, please. In previous SDP supports and investment in the type 1 diabetes genetic consortium and similar efforts with other support led to the identification of 80% of the genetic risk for type 1 diabetes. The attributable genetic risk in this particular case probably exceeds any other disease that we're aware of, a multigenic disease. And this knowledge has enabled new research to understand how the genes cause disease and how they interact with the environmental factor. So using that knowledge, we launched the Environmental Determinants of Diabetes of the Youth, or the TEDdy study. You should know that all government large programs have an acronym. And so this TEDdy study is hoped to identify those environmental triggers. Now, this is a difficult and complex thing to tease out, so it requires a huge and long-term effort. To do this, TEDdy is following over 6,000 high genetic risk children since birth until the age of 15. And the study is scheduled to end in 2025 when the last child is 15 years old. Next slide, please. TEDdy researchers are using sophisticated omic technologies shown here, such as looking globally at genes and proteins and metabolites expressed in cells, and looking at the children's genome, their microbiome and virome. And the goal of this study is to find differences between kids who are at high risk who develop type 1 diabetes compared to those who do not, which might lead to the identification of environmental factors or factors that may play a role and may one day inform type 1 diabetes prevention efforts. Next slide, please. TEDdy has already yielded some important insights regarding dietary effects and the probability of developing type 1 diabetes and on potential impact of the microbiome. And data that has accumulated has actually had more transcendent effects than just related to type 1 diabetes pathogenesis. For example, on this slide, you see that investigators in the TEDdy study have determined that the gut microbiome develops in 3 distinct stages between months 3 through 14, 15 through 30, and 31 through 45. And if you can click one time, please. They further note that breastfeeding, even if supplemented by infant formula, slows the normal maturation and is good for the infant's microbiome. And then click one additional time, And it turns out that dietary fibers present in the diet can enrich for gut microbacteria that produce short-chain fatty acids. And these short-chain fatty acids may actually render protective effects with respect to type 1 diabetes pathogenesis. Next slide, please. So how can the information gleaned from TEDdy analysis help us to prevent type 1 diabetes? Well, of course, if we identify a virus or other infectious causes of type 1 diabetes, a vaccine might be developed or new hygiene guidelines may be recommended. If the analysis, on the other hand, finds that there are dietary factors contributing to the development of type 1 diabetes, then changes in feeding practices can be recommended. Thus, the knowledge gained from the long-term TEDdy study has really the potential to revolutionize our ability to prevent type 1 diabetes. And an important question remains, though, if we can identify a possible environmental trigger through TEDdy, how will we test preventive approaches based on these findings? Next slide, please. Well, we have, luckily, through this special diabetes program, or that SDP support that I've told you about, we already have an infrastructure in place to conduct such studies. The type 1 diabetes TrialNet is in place. Type 1 TrialNet is a large, collaborative, international consortium, in fact, for clinical trials for therapies to delay or prevent type 1 diabetes progression, such as preventing the disease from progressing from stage 1 to stage 2 to clinical diagnosis. If you can click, please. TrialNet has been testing a variety of approaches to prevent type 1 diabetes by interfering with the autoimmune process. Thus, the consortium is already uniquely poised to test new preventive approaches identified by TEDdy and other research efforts. Because prevention trials require screening of large numbers of people, TrialNet has screened over 220,000 relatives of people with type 1 diabetes to date, and 1,260 people have been enrolled in prevention trials. Most people diagnosed with type 1 diabetes do not have a relative with the disease, and therefore anyone who tests positive for 2 or more antibodies is invited to participate in TrialNet. Participants may even enter without a family history. Because of the large scale scope needed for screening, stage 1 and stage 2 trials being conducted by TrialNet, it is almost certain that this would not be conducted by industry. Next slide, please. Well, TrialNet's goal is to test therapies to delay type 1 diabetes progression in people with preclinical type 1 diabetes. That is stage 1 and stage 2, as shown there below. In our Pathways to Prevention study, has led to a tremendous amount of new knowledge, even about the natural course of development of type 1 diabetes, including a paradigm shift, if you would, in the way that the disease course is defined. For example, individuals with stage 1 test positive for 2 or more type 1 related autoantibodies. And we know now that 35% of this stage will progress to clinical diabetes in 3 to 5 years. Those in stage 2 not only test positive for 2 or more autoantibodies, but they also have abnormal blood sugar levels. And in this group, 70% in this stage will progress to clinical diabetes in 3 to 5 years. Now, screening and monitoring individuals under this Pathways of Prevention is the most extensive and expensive aspect of TrialNet's portfolio. And because of the relatively low prevalence of type 1 diabetes and no nationwide screening program, TrialNet is really the only way that these studies are possible. Only TrialNet, not industry, could conduct these trials. And TrialNet has already completed testing of numerous approaches to preventing type 1 diabetes. Some of the most exciting results so far has come from immune modulatory medications, such as teplizumab, or anti-CD3 shown there right under in that box, right under stage 2 disease. Next slide, please. This slide illustrates some very exciting work that for the first time teplizumab was able to show an ability to delay type 1 diabetes from developing clinical disease in individuals who are at high risk, which was the primary endpoint. You can see the Kaplan-Meier curves there, but extended follow-up, and that paper, by the way, was published in the New England Journal in July of 2019. But extended follow-up now shows that the median time to diabetes is approximately 5 years in the teplizumab group compared to slightly more than 2 years in the placebo group. So just actually updating this results, that's a 3-year delay. That's 3 years is critically important in that the people, the individuals didn't have to take insulin. It was 3 years that they didn't have to check their blood sugar levels, 3 more years of good health toward preventing or delaying type 1 diabetes complications. 55 individuals or participants were under the age of 18, and any delay of diabetes during this critical time in their development could really have a large impact on their future health. Next slide, please. Another key element of our approach to conquering type 1 diabetes, the Human Pancreatic Analysis Program, or HPAP, is helping to drive progress in other programs at the same time, and may also help to drive research in type 2 diabetes. In this particular case, if you our HPAP procurement and processing network is enabling a major advances in imaging technology and in determining what happens at the single cell level during and after leading up to the development of diabetes. If you can click once, please. This data is already generating information that's made possible and available to the broader community at the single cell level, actually looking at the cells and what types of cells exist in these cadaveric samples, and even looking at glucose-induced insulin secretion, for example, at this level. This shows that our programs interlock and support one another, delivering more than the sum of its part. If you can click one more time, please. And one final note to emphasize is that the remarkable advances in technology that HPAP has helped to pioneer to enable us to answer questions about what is occurring metabolically at the single cell level, as illustrated there in panel D. Impressively, this shows that there are insulin secretion defects arising in individual beta cells early in the autoimmune process, even before the advent of frank diabetes. And as promising as these lines of inquiry are, we're also advancing the way type 1 diabetes is being treated in patients today. And a critical element of this has been our investment in artificial pancreas technology, as illustrated on the next slide. So researchers in this case have been able to perform a systematic review of 40 randomized controlled trials that compare artificial pancreas systems with any other type of insulin-based treatment. And these trials test multiple different experimental artificial pancreas systems, both insulin only and dual hormone, including insulin and glucagon, for example. The researchers concluded that overall, these systems were safe, effective at keeping blood glucose within normal limits, as illustrated on this chart, with the artificial pancreas treatments doing better to the right there. These results were also found when the analysis was restricted to trials held under normal living conditions without remote monitoring, which really provides supporting evidence that these systems are convenient and easy to use during daily activities. And as a direct result of the special diabetes program, we were able really to jumpstart a lot of the activities in artificial pancreas technology. A number of years ago, there was only one of these that was FDA approved. Now there are several, and now we're beginning to see second and third generations of this AP technology. And so that has really been a very not only inspiring, but very encouraging sign in terms of better treatments for people with type 1 diabetes. Now, I'd like to pivot from type 1 diabetes studies to tell you about some of the things that we're doing with type 2 diabetes, as illustrated on the next slide. And just as I showed you that map on type 1 diabetes and illustrate the number of acronyms or ongoing studies at different stages, here I'm showing you that NIDDK's clinical research programs are addressing every stage of type 2 diabetes, from pre-diabetes through advanced diseases, and transforming our understanding of the disease while simultaneously ushering in clinical improvements in its prevention and treatment. One of our programs we think is poised to have a major effect is our accelerating medical partnerships. They're abbreviated as AMP Type 2D. If you can click for the next slide. One of the key elements or challenges is in the era of big data is making these data accessible to the broader scientific community. And the scientific and the Accelerating Medicine Partnership, T2D project, was initiated with an explicit goal of comprehensively collecting genetic and related trait data from type 2 diabetes studies all over the globe and developing tools to allow non-geneticists to mine that data. This partnership involved, as you can see on this slide, 5 pharmaceutical companies, the NIDDK, and major patient organizations such as American Diabetes Association, Juvenile Diabetes Research. And that was developed to turn data on genetic variations contributing to diabetes into deeper insights on potential therapeutic targets and disease precursors. In a sense, turning maps into mechanisms and those mechanisms into medicines. Next slide, please. The plan was very ambitious, but this program exceeded all of its goals. As you can see here, the inception was in 2015. The AMP Type 2D knowledge portal now contains a vast amount of data and powerful tools to aid in its analysis. And it's all accessible to the broader community of scientists and clinicians. And tools in this portal allow each user to customize their queries to across a wide array of traits related to diabetes and co-occurring conditions. And key elements of this program are that it was built anticipating an exponential growth, as you can see on the graph on the right, a exponential growth in data related to genetic underpinnings of type 2 diabetes, an integration of epigenetic and genomic data beyond genetics to enhance biological insights. We also develop a federated structure which allows for access to data outside the United States while respecting researchers and governments' rules and thereby increasing ethnic and racial diversity of this data. And importantly, we're developed from type 2 diabetes has formed really a key model for information portals that have followed it. And there are several, we were explicitly asked that this be built in a disease agnostic fashion. And several other disease groups have now developed using this model to follow the same model that we've set up. Significantly, these newer websites have been integrated with the type 2 diabetes knowledge portal to yield really a bonanza of linked data as illustrated on the next slide. Next slide. Yeah, and we have recently implemented plans to expand this AMP type 2 diabetes over, say, the next 5 years, with a particular focus on metabolic diseases and conditions that many times co-occur in our patient populations. So instead of it being the AMP type 2 diabetes, we've now transformed this into a vision of AMP common metabolic diseases that were currently built. So we've renamed that portal to reflect this vision. In addition to type 2 diabetes, the portal already contains significant data sets from a number of these conditions, such as obesity and cardiovascular disease. And we anticipate that other diseases within our mission, such as kidney disease and NASH, or non-alcoholic steatohepatitis, will be represented in the portal as we continue to grow. I would strongly urge you to see for yourself by visiting this website, hugeamp.org. It really is very user-friendly. You don't need an advanced degree in informatics or in genetics to utilize it, to pose questions, and to obtain your data. In fact, we've heard that there are high school and college kids actually using this for their science projects. Next slide, please. I'd like to now turn to a vexing problem in type 2 diabetes clinical research, and that is how to treat the growing number of young people with this disease. And we know that this is a problem because we are well aware that this problem exists in many sites, particularly in the South and particularly in Louisiana. Next slide, please. Well, the search for diabetes in youth study showed that pediatric type 2 diabetes is increasing at a dramatic rate, as shown on this slide, especially in racial and ethnic minorities. These were data that were obtained from our sister agency at the Centers for Disease Control and Prevention through from 2004 to 2012. If you click one time, please. This slide just indicates that it's growing greatest among American Indians, non-Hispanic Blacks, and Hispanics. If you click one additional time, I believe that you can see here that the data, this is a slightly different color, but it indicates that these numbers, when you expand this out to 2016, continues to grow at that rate. Next slide, please. And unfortunately, the NIDDK-led TODAY study, which stands for Treatment Options of Diabetes of Adolescents and Youth, study showed that metformin, as indicated here on these Kaplan curves and indicated, shown in blue, it's an excellent first-line drug for adults with type 2 diabetes, and the only oral medication currently approved for pediatric type 2 diabetes is ineffective, particularly in some of the group most at high risk for type 2 diabetes. You can see here that overall, by 60 months or 5 years, less than half of the individuals had reasonable glycemic control, or said the other way around, exhibited failure of glycemic control. And the panel on the far right indicates that this was actually most pronounced among African Americans, kids, or non-Hispanic Blacks, again shown in blue, in which there was a 66% failure rate within that group. Why do young people with type 2 diabetes respond differently from adults who have had the disease for a similar length of time? Next slide, please. Well, the data from our Restoring Insulin Secretion study, again, here's a nice acronym, RISE, shows that the pathophysiology of type 2 diabetes is different in young people compared to adults at a similar stage of type 2 diabetes progression. The young people were much more insulin resistant and their beta cells were hyper responsive to rising glucose levels. And we still don't know why that is, but it's clear that the disease process varies at the age of type 2 diabetes onset. You can see here, again, on the left panel, the youth are more insulin resistant and their beta cells are hyper responsive as reflected by the measurement of C-peptide. Next slide, please. Well, this slide summarizes what we know about the differences between pediatric type 2 diabetes compared to the disease when it develops in middle age or later years. It's more aggressive, less responsive to metformin, beta cell function declines considerably faster, there's lower insulin sensitivity, hyperresponsiveness to beta cells, and something that I didn't show is that there's reduced insulin clearance. Next slide, please. So if the differences between pediatric, if there are differences between pediatric and adult type 2 diabetes, but there are also differences among adults, and it appears so. Let me just, by way of acknowledging this, let me introduce two patients, Mr. A and Mr. B. Mr. A is a younger, and if you can click, I think once, yeah, there we go. Mr. A is a younger, and he has a lower BMI, so we might expect him to be healthier. However, in his case, metformin fails within 2 years, and his A1C has risen. And he also has begun to develop clear signs of diabetic complications. Mr. B, on the other hand, although older and heavier, has controlled his diabetes well with just metformin for 10 years and is experiencing no signs of its complications so far. So it's almost as if they do not have the same disease. And it begs the question, are there distinct and defined subtypes of type 2 diabetes that distinguish people who will respond differently to therapy or who may not ever go on to develop any of the diabetes dangerous and debilitating complications? Next slide, please. Increasingly, researchers suspect that the answers will prove to be yes, as illustrated by the publications shown here. And if differential diagnosis can reliably achieve, and it's quite possible that someday soon, clinicians will treat people with different type 2 diabetes subtypes in a distinct way in order to optimize outcome. Well, this is a central goal and a drive towards precision medicine, which is defined on the next slide by when President Obama recognized the promise of precision medicine, saying that it's an emerging approach to disease prevention and treatment that takes into account people's individual variations in genes, environment, and lifestyle. Next slide, please. And he highlighted at the State of the Union address $130 million project for NIH in 2016, the creation of a voluntary national research cohort, and to find better and treatments for cancer. You can see here, diabetes is also highlighted, creating a voluntary national research cohort and a commitment to protecting privacy, regulatory modernization, and a public-private partnership. Next slide, please. Well, the NIH used part of these funds to establish the All of Us initiative, which we think will lead the way toward improved personalized care for numerous diseases, diabetes not the least among them. If you can click once, please. Click, please. Okay. Well, I'm sorry, if you just go back one, I thought that maybe the animation changed. Just go back one. Developing a new disease classification, of course, ties directly to what we've been discussing, and this is really believed in the future of clinical research and therapy, as mentioned in the title of my talk. Okay, now you can click. Here at NIDDK, we recognize that there are outliers who may initially be diagnosed with one of the major types of diabetes, type 1 or type 2, but whose disease stems from a different etiology, adversely affecting their glucose metabolism. Therefore, we recently established the Rare and Atypical Diabetes Network, or RADIANT, to identify and characterize some of these rare forms of diabetes mellitus. Not only will this teach us better how to treat these individual patients, what we learn from them about metabolic regulation may one day benefit people with type 1 or type 2 or gestational diabetes. Now I'd like to switch gears for a moment to address a topic that we feel has not received enough attention to date: non-biological contributors to disease. Next slide, please. These slides illustrate how social factors correlate strongly with the rate of diabetes. This suggests that if you want to bring down diabetes prevalence in our nation, and particularly if you want to address health disparities, we cannot afford to keep a narrow focus on genetics and other traditional biological factors. Next slide, please. NIDDK is committed to developing a more robust research program to identify some of the social determinants of health that contribute to health disparities in disease in our research mission. Next slide, please. NIDDK is committed to developing a more robust research program to identify some of the social determinants of health that contributes to health disparities in the disease in our in this research mission. Next slide, please. and that that disparities of social determinants of health are conspicuous in any thoughtful consideration of effects of pandemic on our health population. And as clinicians, it's critical to recognize that this is the reality of our vulnerable patients and are currently facing. Let's see, next slide, please. Within a context of diabetes and obesity and health disparities, researchers from multiple disciplines need to tease out the molecular underpinnings, for example, for the acute and long-term COVID-19 symptoms, identify treatments and preventive strategies that work best for different populations, identify and find ways to address the most critical social determinants of health, and to reduce COVID-19 severity and related complications. My colleague, Dr. Cephalou, and I just recently reported on this in a publication that appears in Cell Metabolism about a month and a half ago, and I'd invite you to read some of the content of that. Next slide, please. But COVID-19 not only affects very vulnerable populations served by NIDDK, its consequences extends to nearly everything that NIDDK supports, as shown on this slide. Research projects, programs, and clinical trials that were underway pre-COVID have been stopped or delayed for safety reasons, in turn stalling and delaying new discoveries. The cadre of scientists we support face great uncertainty and challenges in making progress in their fields and their career, especially young investigators just starting out, and women investigators and others who are disproportionately affected by caregiving roles during the pandemic, and members of underrepresented groups we've been hoping to attract to the research workforce long before the pandemic. We're also seeing research costs increase. The burden of restarting clinical trials, animal colonies, and other programs and resources is made even more challenging by the need for additional funds and strategies to conduct research safely in the face of COVID-19. personal protective equipment, extra cleaning, and time sharing in the laboratories are just a few examples of this. And ultimately, there are likely many lost opportunities to pursue new research questions. These changes show why our commitment to supporting the next generation of NIDDK scientists is critical, which really brings me to my next point. Next slide, please. And that relates what I told you I wanted to sort of end on, a word about our NIDDK training programs. Next slide, please. The NIDDK has a scientific workforce development initiative designed to support transitions at every stage of career development. And in this context, we have an emphasis on young scientists of color. If you can click once, please. We identify, for example, if you look at the bottom, that from the stages of high school and undergraduates, graduate school and postdoctoral, early people coming into their career, we know, for example, that they, in many instances, take on enormous amounts of debt. So shown at the top of that, we have a very vigorous loan repayment or LRP program to assist in that barrier to move to the next step, that transition to junior faculty member. And shown on the under the bottom of these graphs, particularly at the transition points, are areas of emphasis related to the various mechanisms that are in place, both training and fellowships, as well as career awards. But then moving from that junior faculty member to receiving your very first R01 support, we offer workshops for new PIs. We offer additional bonuses for early stage investigators, that is, individuals receiving their first award. We have small grant programs to promote diversity and health-related research. And then the sort of on the next step is moving from an independent faculty member up to a sustaining member, receiving either your first renewal of your R01 or getting a second R01. We offer additional bonus points for ESIs renewing those applications in an effort to maximize our pay line. As I mentioned, there's always been this sort of analogy of sort of a leaky pipeline and how early do you start to initiate these processes. We have active programs at the high school and undergraduate level, a program called Astronaut that focuses on individuals from rural parts of the country, a medical student program that I'll tell you a little bit about in a moment, efforts in conjunction with the National Medical Association, the National Hispanic Medical Association to offer physician scientist travel awards, and a very robust network of minority health research investigators, which puts together oftentimes virtually matches junior faculty with more senior faculty to provide additional career advice. And because we realize that the future is clearly in the area of big data and bioinformatics, we've developed new programs at the very early training stage and then in the career stage to have people retool in the area of bioinformatics support. Next slide, please. I told you that I would tell you a little bit about this medical student program that is now on into its 11th year of existence. But most notably, you'll see here that in 2020, the program had to be put on pause because, just as I mentioned earlier, COVID really touches everything. This program has been actually quite successful in that through a supplement to our diabetes centers and to their T32 programs, as well as our Diabetes Complications Consortium, we've provided additional funding to match medical students from over 120 medical schools in the country, particularly those that tend to be less resource-intensive medical schools, link them with these diabetes training centers or diabetes complications consortium to give them a summer experience in doing research in the labs. This really has provided two benefits, or at least two benefits, but one, giving people an opportunity to be engaged in research in diabetes, and hopefully giving their colleagues at these more research intensive opportunity to see individuals from medical schools that perhaps they may not have thought about when considering residencies, fellowships in diabetes in subsequent years. And we believe that, of course, any introduction and a vigorous and rigorous training in the scientific method would, of course, provide a benefit. Rather, these individuals stay in biomedical research as a future career, or actively go on and are engaging in practice. Next slide, please. And lastly, I just want to emphasize our role to try to bring professional society programs into the fold in order to work with them closely on our overarching and related effort to try to promote diversity within their programs. This program has been actually quite successful. Now we have, as illustrated on this slide, 4 professional societies all engaged in work related to what NIDDK's mission area are, including the Endocrine Society, the American Gastroenterology Society, the Academic Pediatric Association, and the American Psychological Association, now developing programs targeted at their membership, which include both comprehensive training as well as getting them engaged in certain areas within the society that will hopefully sustain this as time goes on. Next slide, please. So that concludes my talk. That brings me to the end of the talk. I once again want to thank you for this very kind introduction and the ability to return me virtually to my home there in Louisiana. And with that, I'm happy to answer and take any questions that you might have. Thank you very much.
Thank you very much, Dr. Rodgers, for the excellent overview of what's going on in the field of NIDDK, mainly diabetes, obesity research. If anyone has any questions, please type it in the chat box, and I can read it out to Dr. Rodgers. But let me start. You've given us a very broad overview of many programs, many of which we are involved, such as all of us.
Absolutely.
There's also PCORI-PCORNet that has quite has had quite a diabetes emphasis. Is there any strategy to bring these all together so that you can use resources of one while you're doing something in another? We often do reach out as part of the engagement part and stakeholder engagement, but is there something formal that you could talk about?
There's nothing formal that I can tell you at an NIH-wide level. I think your point is very salient, and in fact, this is certainly opportunities that we sort of take and realize. We're always involved in stakeholder questioning and asking, for example, our center directors and some of our program training people, how could we use these programs, the infrastructure created in these programs, more effectively. And in fact, that was really the origin, for example, of our medical student training program. When one of our council members says, you already have the structure, why don't you just put some additional funds to provide supplements and to set up this program? And I can tell you of 3 or 4 other examples that NIDDK has sort of taken up. But you're absolutely right. When you have these programs already set in place with just perhaps small amount of incremental funding, one could actually make the overall better than the sum of its individual parts.
Yeah, a good example there would be the All of Us program, which is not really about genetic diseases. It's about everything. And,
Sure.
we need to have a group of people address diabetes within this subset of 1 million people, which eventually could mean maybe 100,000, 200,000 people, and have a wealth of data that could be looked at.
Yeah. Well, one example of something that we've been engaged in related to the All of Us program, for example, is to answer a very simple question: what should we be eating? Everyone has their own diet du jour, and some people will say Mediterranean is better than low fat, and keto is better than that. But we really don't know. And as I'm sure I know you're well aware that what the variations that we have in blood sugar level and in important analytes varies differently from one individual to the next. And some of the things that are responsible for those variations include the person's genetics, their environment, their other factors, their microbiome, for example. And a program that we've helped to establish that'll be one of the first ancillary studies to the All of Us program is a program called Nutrition for Precision Health, or NPH. You would recognize that acronym. NPH hopes to solve a very simple question: is what, given all the factors that determine this variability, what is the most precise eating plan that I should be engaged in? And we hope over the upcoming years that this program will be powered by the All of Us, that will be able to gather information. But in a similar way, other ancillary programs might be anticipated.
So there's a question that's come in addressing the social determinants of health, race is a key categorization. Personalized medicine and All of Us relies on individual genotype and life experience. How will we rationalize these two disparate theoretical frameworks, especially given the genetic heterogeneity of Blacks?
Yeah, yeah. Well, I think that information on race will certainly be included in that context, but that's just one variable. Some of the ancestral data based upon the genotyping and admixture will be factored into the equation as we look for key variability. Um, Within our particular field of great interest, the NIDDK, for example, and something that there's been a lot of controversy about recently, and I have to say, oops, that Tulane University has been participating in this by virtue of its participation in our chronic renal insufficiency cohort, or CRIC, poses a question of whether what we normally do in terms of estimating the GFR, there's an equation that takes race specifically into account. And while there are many that show that this really does more appropriately approximate the GFR, there are some that say that race is really a social construct, and shouldn't you include information about the genetics? As it turns out, when you do include genetic information, it provides almost the same information in terms of estimation that race does. But there, I'm sure, will be circumstances in which, for one reason or the other, there's one that will actually fare better in terms of estimations of equations when one utilizes artificial intelligence and machine learning to drill down on these large data sets that we're now collecting.
So keep the questions coming in. Can I ask people to also complete the evaluation? That you've got a survey link. Anybody else on our panel? John, do you want to comment?
Yeah, no, I just actually gave you a question on the chat, but I can do that directly. Thank you, Dr. Rodgers. Really great expose and a great broad overview of the diabetes field and research that's ongoing. Certainly was very helpful to me, and I hope to everybody that's tuned in. We did have great participation, by the way, and we appreciate everybody who queued in for this. But I have a question related to COVID, and that is there's an ongoing debate vis-a-vis diabetes and COVID. Does COVID worsen diabetes symptomology? Does it increase the rate of progression from pre-diabetes stage to diabetes? Or is it in fact the reverse? Because early on we heard comorbidities like diabetes put people at increased risk for hospitalizations related to COVID. So I'm just wondering what your views are on that.
Yeah, actually, that's a very good question. In fact, I think that that's an area in which we still have more questions than answers. A few months back, we hosted a diabetes interagency coordinating committee in which we brought a number of federal agencies together, VA, FDA, CDC, and other representatives to really kind of tackle this question. And we had some very skilled investigators that provided information both ways. If Dr. Cefalu is on the line, he actually chaired that meeting, and he may, a former participant in this program, may have a few words to say in terms of the outcome of that. But at the moment, if he isn't able to participate, I can tell you that there's still many more questions than answers to that. And that's an area of that we're very particularly interested in focusing in on, particularly as it relates to this long COVID syndrome,
Right.
whether once people are infected, either it accelerated development, for example, of diabetes, or maybe there's a rarer form that would have different types of a phenotype than what we're typically used for in the case of type 1 and type 2. Will or Dr. Cefalu, are you available to make a few comments, or maybe he's tuned out already?
Unfortunately, Dr. Rodgers, it looks like he's left us.
Okay, all right. He has probably another meeting to go to, but stay tuned, Dr. Kerwin. This is an area that NIDDK is very much interested in getting further information on.
Thank you for that. If I have a second, I'll make another comment or question. It relates to your shift to the social determinants of health. So typically, at least from my perspective, a lot of the research that we've been doing around the diabetes has been more on the biological side, right, and on the pathophysiology. But here we have this increased need to understand social determinants of health and the impact that has. And there's a lot being said about that relative to ethnicity and race. But I'm curious as to what your perspective is on rural versus urban, where some of the actual impact of the social determinants of health are even greater, perhaps, because of lack of resources and so forth.
No, absolutely. And when we say social determinant of health, it doesn't restrict it to race and ethnicity. It actually includes exactly, the points that you're making. In fact, it's surprising that even in the nation's capital, one could go just a few metro stops and the average life expectancy, at one of those stops could be considerably 4 to 7 years less than if you were to go into a more affluent, area of the city. And that is clearly the distinction. The distinction between rural and urban may be even greater than, for example, on average, than what you see related to race and ethnicity. So the social determinants and where people live and where people work and where people, worship may have a lot more to do with their overall health, particularly in chronic diseases, due to their income, to the availability of, food within their communities, fresh fruits and vegetables, for example, their exposure, on the other hand, for example, to living close to railroads and highways and the industrial pollutants that they're potentially exposed to. All of that is going to be taken into account as we begin to look at the role that some of these exposures and our ability now to track them more precisely using things like GPS mapping and the ability to, for example, measure in environmental analytes, the so-called exposome technology, in determining how all that fits together in determining someone's health. And it's not just external environment. The microbiome, we think, plays a major role as well, both in terms of health and disease, particularly immunologic diseases, but also it may produce epigenetic marks that we're currently unaware of. We're one of the lead institutes engaged in research and sponsoring research in the microbiome. And so that's another area fruitful for investigative inquiry.
Thank you.
Thank you.
Dr. Rodgers, there are a handful of questions in the Q&A. Can you stay with us just a minute more?
Yeah, let's go for another 2 or 3 minutes.
I appreciate that. Thank you. The first is, what kind of similar research is the NIDDK doing regarding inflammatory bowel disease?
Yeah, we really have a very vigorous program in inflammatory bowel disease, similar to what I showed as I was highlighting the type 1 and type 2 diabetes with a very large consortium to understand its genetic underpinning. For the last 15 years now, we have sponsored the Inflammatory Bowel Disease Genetic Consortium. It was a time that no talk on inflammatory bowel disease could be given without nod to so-called NOD2, which was one of the first genes implicated in the pathogenesis of Crohn's disease and ulcerative colitis. And this consortium has really accumulated a large number of genes and gene regions, which appear to either provide an accelerated course and be major risk factors, or alternatively may provide protection in family members at high risk for inflammatory bowel disease. We've moved that from an understanding of the genes to developing the pathways that they're involved in, and from that looking at novel drugs that might interfere with some of these pathways. You may be familiar with some of these that are advertised almost every night, with some of these immunomodulator drugs that specifically target inflammatory cells that reside in the gastrointestinal mucosa, such as infliximab and others. A lot of that work was really based upon fundamental basic science that was derived from this inflammatory bowel disease genetic consortium. We have other efforts to develop humanized models of these disease to try to understand it even in greater detail, organs on a chip technology. And I can go on, but suffice it to say, if you'd like to get more information about the range of activities that we are currently engaged in, as well as future opportunities for research, please visit our website at niddk.nih.gov.
Excellent. Thank you, Dr. Rodgers. We have a handful of more questions, but let's see if we can just ask this as our last one for the day. And we'll follow up with you perhaps and ask you to answer.
Maybe I'll ask one last question. And
Okay.
we have a lot of young investigators on the line today. Dr. Rodgers, in a couple of sentences, what advice would you give them?
Well, I would advise them to work closely with great mentors like yourself and Dr. Kerwin to stay the course. There is a lot of emphasis on biomedical research that's will be coming to the fore. We realize, for example, that if it wasn't for science, this pandemic that we're currently involved in, might be even more of a protracted course. But I think we can all agree that we're beginning to see the light at the end of the tunnel. And that's only because of we were poised to, for example, use what we've learned in the past to accelerate the development of key vaccines targeted at, for example, the COVID-2 vaccine, and even prepared to now come up with boosters that will take into account these variants. But in a similar way, beyond sort of the infectious disease area of science, there are other things that are just, at that same precipice. But what we need is outstanding people committed to a research career, both at the basic, the translational, and the clinical level. Our institute and several other institutes are trying to redouble our efforts. We realize that, young scientists have been disproportionately affected by this lack of activity over the last year. We're trying to make provisions for that. And so really stay the course. This is an area that we really need all of you to help us moving forward. And so really connect with a good mentor, someone who can give you good counseling advice, but we really do want you to participate.
Thank you. And thank you very much for giving us so much of your valuable time this afternoon. That was a great lecture. We've had wonderful comments in the chat box, and I look forward to seeing you in person soon.
I do too, as well. Thanks so much for giving me this chance, and really look forward to seeing you in the not too distant future.
Great. Thank you very much.
Thanks.